A warm welcome to all participants on the name of ULIT, its board and associates. Over the next 20 minutes, I will try to talk about the present status of shockwave lithotripsy, and I will try to find out why it's not in the place that it deserves really. What are the factors, and how shall we overcome all these factors in order to bring it to its deserved position? First, I will begin with some facts, with some slides. This is a very old slide, and despite its being old, the figures here you see, depending on stone size, shockwave lithotripsy will be really very effective in the management of stones. Here you see stones sizing less than 1 centimeter will be disintegrated in a high success manner. Around 25% stone-free rates could be anticipated. Again, here you see if the stone size is less than 15 millimeter, stone-free rates are more than 80%. Auxiliary procedures and repeat procedures will be really accepted in this position. And shockwave lithotripsy and URS in clinical practice, when we evaluate the American Urological Council originated certifications, here you see of all the certifications given, physicians, around 61% of them did choose shockwave lithotripsy in the beginning to treat the stones. I mean, stone and patient-related basis. On the other hand, when we evaluate the variation of the techniques in 10 years period, in 1997 and 2007, a total of more than 9,000 cases have been evaluated. And here you see physicians again did choose shockwave lithotripsy as a primary choice in around 56% of the cases. These data are coming from my department between 2018 and 2019. When we deal with the stone sizing less than 15 millimeter again, here you see around 52% of the cases with such stones were treated with shockwave lithotripsy in my department. But despite all these facts, we know very well, in the recent years, in the last 10 years maybe, there's the question, shockwave lithotripsy is losing its, let's say, popularity among the alternatives that we use. Here you see coming from the meetings, coming from the publications, contemporary surgical trends in the management of tract calculi, as you see here, although ureteroscopy and PNL is increasing in practice, shockwave lithotripsy did lose its popularity to some extent. In this study, you see 6 different countries, and share of URS did increase 17%. PNL stayed stable. However, the share of shockwave lithotripsy among the treatments decreased around 15%. But there are some factors. Here you see endourologist versus non-endourologist. When we learn the endourology using the instruments and begin to work with endourology, then we a little bit becoming away from shockwave lithotripsy. The more we learn in endourology, the more we operate, and the more we go away from shockwave lithotripsy. That's the reality. The question is now, is really the shockwave lithotripsy dying? The question is coming despite some popularities, despite some facts. We know shockwave lithotripsy is the true non-invasive procedure that we can use at the moment. There is no need for anesthesia. There is no need for hospitalisation, low complication rates, high success rates, and low costs could be anticipated with this modality. Then why the popularity or the practice with shockwave lithotripsy is decreasing? This is somehow related with, we know the result of shockwave lithotripsy vary considerably between the centers and the operators. On the other hand, technical advancement in endourology procedures did cause this decrease in popularity of shockwave lithotripsy. Insurance policies, reimbursement systems, and patient expectations are very important. Then what we should do to improve the shockwave lithotripsy outcomes? We need to have proper patient selection indications, and we know about the contraindications very well. We need a dedicated team to work together with shockwave lithotripsy, and we should operate through the technical details. And also, realistic patient expectations, proper patient informing is very important. Proper patient selection is the PSA of stone management, coming from my dear friend Paliosta, personalized stone approach. And if the aim is to render the patient stone pre, we need to take the patient-related, stone-related, and also the other anatomy-related factors into account very well. When it comes to evaluation of the stones, very important. CT evaluation is very important for proper patient with the stones evaluation. Stone volume, stone location, stone to skin distance, stone density, and in recent years we have this ability or opportunity to evaluate stone heterogeneity index and CT texture analysis of the stones. And by using them, here you see in this study, the authors did use triple D score. D score is a reportable predictor for shockwave lithotripsy stone-free rates. They evaluated stone volume, they evaluated skin to stone distance, and stone density. And in the end, they were able to predict the outcomes of shockwave lithotripsy if they use them very well. A prediction model using machine learning algorithm have been used in this study, a recently published study, and here you see around 93% accurate decision could be made by using this machine learning algorithm in order to get an idea about the results of shockwave lithotripsy. On the other hand, this is a publication coming from my team, and here you see if we evaluate when we deal with the ureteric stones, particularly the proximal ones, if we evaluate the ureteral wall thickness in the CT images around the stone itself, this is a very good indicator in order to predict the likelihood of success rates or disintegration rates after shockwave lithotripsy. And here, again, the authors did evaluate 4 significant parameters: stone density, stone size, stone to skin distance, and also presence of JJ stent. And by using them, again, they were able to predict the outcomes very well. The other very important factor is we need to have a dedicated team. Outcomes of any surgical procedure improves with expertise. We know it very well. And success rates will increase, complications will decrease. But we need to operate by the book, by the technical details, tips and tricks when it comes to shockwave lithotripsy. And I should emphasize that urologists, they themselves should be the operator. They should do the procedure by themselves, and then they will have the chance to talk about the procedure. But at the moment, I know in many centers, technical persons are operating, and the urologists just talking about the results of the procedure. They don't even have no idea about the procedure, or they don't do it by themselves. Are RARS or PNL performed by any technician or nurse? Why? It is the fact that the technicians do the procedure when it comes to the shockwave lithotripsy. Here, from technical aspects, we may lower the shockwave delivery rate. Stepwise gradual increase in the energy level is very important. Ramping, an educated and well-planned pain control, well-established coupling, and also well-designed, precise localization systems. In recent years now, we have really new lithotripter types that are very effective, very successful in terms of stone disintegration. Here you see we need a controlled, optimum, persistent, and reproducible energy production. When we compare the electrohydraulic systems that we used in the past, electromagnetic systems here today we use are really very well accepted and successful on this aspect. When we compare HM3 and dry lithotripsy, we know that in HM3 patients had to be involved in order to have the coupling, but in dry lithotripters we have the therapy head. But when it comes to the therapy head, an excellent coupling is very important for energy delivery, and when we have the air bubbles in the therapy head, then the success rates will go down. And now in some systems, for example, now I'm working with Dornier Delta 3 systems, and it has a surveillance camera inside in the shockwave head to see and to, let's say, monitor the coupling, if it is all right, if it is excellent or not. That gives us the chance to see the air bubbles, if there is any or not. And when we have this system, when we monitor the coupling, if it is good or not, then success rate will go up and retreatment rates will go down. Number of shockwaves also will come down. Reduction in analgesia, more effective powdering, and also more clearance rates will be anticipated if we have a really a good coupling. On the other hand, with these systems, again, we may change the window of shock lithotripsy during shock lithotripsy in order to have the stone enlarged very well to disintegrate it. That's also another chance if we do it by ourselves, and if we know that the system has this modality. On the other hand, enhancing the image during shock lithotripsy is very important. It will reduce the radiation, and stones, irrespective of any chemical composition, will be targeted very well, and live monitoring and tracking of the stones will be really helpful to us. Here you see Optivision modality of normal delta 3 is a unique property, and you can see all the stones instead of in, let's say, obese patients, bowel gas, or radiolucent stones will be no more problem for us during the treatment. How about reimbursement and insurance systems? At least in my country, we know that PNL and URS, they are being paid very well when it's compared with shockwave lithotripsy. Here you see it's being paid very less amount of money, and this will affect the decision of the urologist in order to treat the same size stones. Value should be adjusted to clearance of stones, complications, and success rates. And I may ask the question, if the insurance systems pay the amount of money that they will pay, depending on the results of the procedure, then how many urologists will prefer a ureteroscope or PNL for 1.2 centimeters stone in the renal pelvis? Patient expectations and needs are very important. That's a very nice study, 8 millimeter asymptomatic lower pole stone. And if we let the patient well about the systems, complications, and success rates, and also practice patterns, and here you see patients will choose shockwave lithotripsy more than the other modalities. And 85% of the patients would rely on the physician's recommendations if we don't tell anything about all available options. Patient education and informing, very important with that. Here you see significant improvement in the level of knowledge, significant decrease in decisional conflict will appear, and in this study, 67% of the patients did prefer shockwave lithotripsy when they have enough information about the procedure. If we tell something about this modality also in detail. In conclusion, to close the gap between ideal choices will come down, and if we have proper patient selection, if urologist operates and do the procedure, if reimbursement systems is revised on this aspect, and also if the patients are very well informed about this procedure, then we will have desired success rate with shockwave lithotripsy. COVID-19 did change something in the last year that we are facing through. Here you see we performed as ULIS 2 different studies, and in this study we were able to evaluate how the practice patterns did really change, and we were able to see that significantly changes have been observed in practice patterns, and urologists, endourologists should be aware of the possible alterations of the surgical options in these conditions. 473 patients, 11 centers, and we evaluated stone-related surgical procedures, preoperative evaluation, anesthesia, and intervention. Here you see we needed to have an additional testing during anesthesia evaluation. Some tests needed to be done in order to begin or have the patient in the OR. And based on the pandemic conditions, elective surgeries have been postponed. Anesthesia evaluations became a must. General and spinal anesthesia and the risk of transmission came our agenda. OR cleansing, sterilization process, and postoperative care. All these parameters became on our agenda, and we needed to be very careful in treating them, in treating the patients with stones. We know that patients want to be stone-free. They want to get rid of stone, but on the other hand, they don't, during the COVID pandemic time, I mean, they don't want to be operated, they don't want to have any anesthesia, hospitalization, complications for both urologists and also patients. All these factors became a real concern. We know that in the future, endoscopes will get smaller. New type of laser will be more powerful. Surgical techniques will evolve, stone rates will increase, and complications will come down. technical advancements will let us to use the digital instruments, new high-power lasers, suction seats, miniaturized PNL baskets, and the other instruments. They will all make the procedures even more minimally invasive. We know it very well. But the fact is not changing. Shockwave lithotripsy will stay as the only non-invasive treatment modality among these alternatives. It's an outpatient procedure. There is no risk of anesthesia-related transmission, no risk of body fluid-related transmission, no need to postpone the treatment as an elective surgery, no need for postoperative care, and if you choose the patient, but more importantly, the stone size location very well, stone-free rates will be high and complications will be really very limited. How about the guidelines? Guidelines are the facts that we are using, we are practicing, and this is the guidelines of 2020. Regarding the treatment of kidney stones, here you see for stone sizing between 1 and 2 centimeters, still shockwave lithotripsy is in the first place as a preferred option, equally effective as the embryologic approaches in the management of such stones. For stones sizing less than 1 centimeter, shockwave lithotripsy is no question in the first place. And when it comes to lower pulse stones, again, if the anatomic factors are favorable, shockwave lithotripsy will be again in the first place to be preferred for stone sizing 1 and 2 centimeters. I mean moderate sized stones. It's also valid for children. In children, in many stones in different locations and size-based, here you see. I may emphasize shockwave lithotripsy needs to be in the first place to choose for children. It's also valid for urinary stones. The question was, is shockwave lithotripsy dying? I may say, as a fan of shockwave lithotripsy, depending on its practice and stone patient-based manner used, it may be losing some blood, but it's not dead. Thank you so much for your kind attention.
Thank you. Thank you very much, Kemal, for this very nice and comprehensive presentation. Great. Also, thank you for demonstrating the actual situation with the COVID and the coronavirus, where we really sometimes have problems scheduling all the patients and that SWL as an outpatient treatment is really an option, which we should not forget. And I think finally, when I see your talk, we can see that basically the indications are almost for every stone besides larger than 2 centimeter stones are for SWL. And I think you made all the points very, very clear. I have it just I would like to have some questions. We have some questions from the audience. For example, they're asking what kind of extracorporeal lithotripter do you have? And for example, what kind of imaging is necessary for the location of the stone when you perform SWL?
Very nice questions. Coming to the shockwave lithotripsy system that I use, now at the moment I'm using Dornier Delta 3. It's a very effective, very user-friendly and very practical system. Two modalities of Dornier Delta 3 are very important for me. One of them I mentioned during my presentation, opti-coupling system. That's the ability, or let's say opportunity, to closely monitor if there is any air bubble in the therapy that will interfere in the shockwave delivery and its effect on the body and on the stone. On the other hand, the OptiVision system, and related to the question that has been asked, OptiVision is very well, very nice enhanced imaging system incorporated in Delta 3. But it's a radial fluoroscopy system. Before emphasizing the importance of this system, I need to tell that all young urologists, they need to learn about sonography. They need to be familiar with use of sonography during the management of stones, both during shockwave lithotripsy and also during PNL. If we use sonography, it will be very practical, and also the risk of radiation during the procedures will come down. During shockwave lithotripsy also, I always prefer to use, particularly in children, sonography for the stones, particularly located in kidney, to localize the stones and also to monitor them during the whole treatment period. It's easy, it's practical, and there is no risk of radiation to see the stones throughout the procedure. But we need to use both systems in balance, and as I emphasized, Optivision system in Delta 3, CT-like images you can have, and stones that are being a little bit radiolucent, body gaze problems, and also very small fine stones could also be seen with this imaging modality. Sonography first, if you have the experience to localize and track, but otherwise, fluoroscopy is also needed to localize and track stones.
Absolutely. We have several questions about double J stenting. So maybe the question is, when would you stent? Because in general, stenting is not recommended in SWL. So it's rather to avoid a Steinstraße. So that's the basic indication. And let's say, when would you pre-stent, or not pre-stent, when would you stent the patients? And what would be the maximum stone size which you would handle, or the maximum number of stones you would treat with SWL? Could you do, each one of you, could you give any recommendation on that?
Also another very nice question. Stenting prior to shockwave lithotripsy is not a routine procedure, and I don't do it. There is no need. And if we treat the cases on a really stone sized or stone volume based manner, then everything will be very clear. We know that stone sizing in some publications it's been indicated as 2 centimeters. For me, stone sizing less than 15 millimeters are the ideal cases for shockwave lithotripsy. And if we choose the stone size or volume in this way, there will really be no need to stent the case, pre-stent the case prior to the shockwave lithotripsy procedure, both in adults and children. And for children, if I open a parenthesis, even larger stones could be disintegrated very well, depending on the size and the duration of the stone in the kidney. Larger stones, for example, 1.5 centimeter stone in a child in one session could be treated very well. To summarize, in very selected cases, if the stone size is larger than 2 centimeters, and if you are really obliged to perform shockwave lithotripsy for some certain reasons, then we may pre-stent the case in order not to have a stone street formation and other complications after the procedure. But if the stone size is less than 2, particularly less than 1.5 centimeter, in routine practice, there is no need to stent the case prior to the shockwave lithotripsy.
Mm-hmm. Maybe one more question about the therapy itself. When would you decide to stop the treatment? On what findings? And post-treatment, when would you do any investigations to see if the patient is stone-free, if he would need another treatment? What are your recommendations on that?
Nice questions again. Sometimes we hear that some of our friends talking about 5th, 6th, or 8th session of shockwave lithotripsy to treat a stone in a patient. That's not acceptable. You are working now, and I worked around 8 years in the guidelines group, and there we discussed the number of sessions, and the maximum number of sessions for a shockwave lithotripsy to be accepted is 3, I may say. If needed, one more, depending on your decision, depending on the desiccation rate, can be performed. But 3 is the maximum number for the sessions for shockwave lithotripsy. But when I begin to treat a stone with shockwave lithotripsy, after the first session, if I see no change in the stone, then I have some question mark in my mind. I may go further and have a second session, depending on the previous history of the case. If I have an idea about stone composition and depending on size, I may prefer or perform a second session. If there is no change after second session, I will do nothing with shockwave lithotripsy and change my policy and get to go further with the use of the other modalities. On the other hand, following the treatment, shockwave lithotripsy, I usually see my patients, if it is a kidney stone, after a week period. if I have no complication during the procedure, after a week period, I invite the case in order to check the disintegration rate and also status, and also if there is any silent obstruction following the procedure. Of course, in between, I always remind the patient that if they have any complaint, any problem, any pain, they come or refer by themselves. But if the postoperative course is uneventful or silent, then after a week period, I invite them and see them, check them in order to see the results of first session. That's not valid for ureteric stones. For ureteric stones, there is no need to wait a week period for the safety of kidney, because this stone is in the ureter, and for ureteric stones, after 2 or 3 days, I'm performing the second, let's say, session if needed, and I see the patient automatically after 2 or 3 days. To assess the final stone-free rate after shockwave lithotripsy, always I see the patient 4 weeks later and 3 months later. 3 months is the last evaluation in order to decide if the patient is completely stone-free or she or he has any stone fragments.
That's true. I think it's important to wait a certain time in order not to have an overestimation of residual fragments, which could also lead to more treatment, which you would like to avoid. Another question, which I think is interesting, is we talk about also emergency ureteroscopy. If patients are in a colic, should we immediately get them stone-free? I mean, there are also some papers on that about emergency SWL. Already for 10 years, we have seen that SWL performed within 24 or 48 hours after the first colic might increase the stone-free rate. Is that a concept you follow? That's something, if a patient comes into your hospital and has a colic or is in pain, would you go for SWL? Is that an option for you?
Exactly. Very nice question. I'm really very thankful for the colleague who asked this question. Emergency shockwave lithotripsy is becoming a fact to be accepted and to be applied in clinical practice. I do it, but in selected cases again. If the patient is coming for a really, let's say, accepted size of stone in ureter, particularly less than 1 centimeter, if the patient has no evident dilatation, if the patient is infection-free, and if only the pain is problem for this case, then after pain control, within 24 hours or after 24 hours, I tend to apply shockwave lithotripsy in order to see the results of shockwave lithotripsy before going to the ureteroscopic. And in the majority of the cases, we are successful, and in most cases, a single session, for example, for a stone sizing 6 or 7 millimeter, particularly in the lower part of ureter, shockwave lithotripsy is effective. The patient is passing the stone fragments, and there will be no need for ureteroscopy, for anesthesia, or anxiety for the patient to prepare himself or herself for an operation.
Thank you. Perfect. I just have to say we get a lot of questions. We will not be able, unfortunately, now to answer all those questions. They're all very interesting. I think we go on with our program, and then we will see that we can combine or try to combine the several questions maybe in a whole. So I would say we go now ahead to our next presenter, to Professor Alberto Budia Alba, and he will talk about future, maybe a bright future of extracorporeal shockwave lithotripsy. And I'm very curious what we will hear. So, Professor Budia.
Good evening, everybody. Thank you very much for your invitation for speaking about the future of shockwaves lithotripsy. Since the original experience with HM3 lithotripter, new advances have been emerged over the last 30 years in order to optimize the results of the effectiveness of extracorporeal lithotripsy. New optimal shockwave generators have been developed. Improved stone tracking software has been designed to facilitate stone location and monitoring them during the treatment, and the selection criteria for patient and for stone composition have been well defined in the main clinical guidelines. The size of generators has been reduced, making the equipment more mobile And the new generators have reduced or have developed narrower focal zone at F2, decreasing the patient discomfort and decreasing as well the potential tissue injury, but with an important disadvantage, because it produces a decrease of comminution efficiency and consequently a lower stone-free rate. In spite of the new advances that I have described before, the care cost of extracorporeal lithotripsy in many countries, not in my experience, in my department, extracorporeal lithotripsy is cheaper than endurologic procedure. The low stone-free rate and the high retreatment rate for some patients treating with extracorporeal lithotripsy and the growing trend in endourology training programs are the main causes of decreasing the use of extracorporeal lithotripsy compared to endourologic procedure like ureteroscopic or percutaneous surgery. So for that reason, in my opinion, the real challenge nowadays of extracorporeal shockwave lithotripsy is to get a stone-fine fragmentation like that achieved by the laser dusting technique. And in my opinion, the novel applications can get it. I agree with Dr. Kemal Sharika that extracorporeal lithotripsy is not dead, because the novel applications can get it. New advances in the understanding of stone comminution have resulted in the novel applications of focused ultrasound to propel and fragment renal stones. So, in my opinion, emerging technologies have potential to revolutionize the treatment of urinary stones. We know that extracorporeal shockwave lithotripsy produce the fragmentation of the stones, and thus is the fragmentation, the comminution is product of the direct energy from the shockwave produced by the high amplitude compressive phase of the shockwave, and is product as well of indirect energy from collapsing of cavitation bubbles produced by the low amplitude tensile. But we know as well that with this technology, with extracorporeal shockwave lithotripsy, the best results were obtained by HM lithotripter, because it delivers shockwave relatively with a lower pressure amplitude to a broader focal zone. So, it seems that these characteristics reduce the excessive production of cavitation bubbles, and so it reduces the attenuation from the subsequent waves that arrives to the stone that can be produced by the remnant cavitation bubbles on the surface of the stone. So the first technology, or the first new technology that I'm going to try to explain is the best wave lithotripsy. It's a focused ultrasound technology that with a compact handheld probe delivers focused sinusoidal ultrasound pulses in short bursts transcutaneously. But the main difference is that it delivers a low peak pressure, not more than 12 megapascals at high rate, not more than 200 hertz. So it's the first difference, or the main difference, and you can see in the picture, is the difference between the shockwave form with shockwave lithotripsy and best wave form. It's difference between the rate and the low peak pressure that it delivers. So if we use best wave lithotripsy, we can increase the efficiency at the stone comminution, because the use of low peak pressure reduces the cavitation bubbles, and so you can reduce as well the attenuation effect produced by the remnant cavitation bubbles. And so it's a safer procedure because you reduce as well the potential damage injury. But if you use at high rate of the liver of this type of waves, you can obtain finer fragment. If you increase the frequency of ultrasounds in these cases, you can obtain a finer fragments. So the way of fragmenting the stone is different between the base wave lithotripsy and the shockwave, because the base wave lithotripsy fragment the stone at the working phase, much like a laser, rather the block fragmentation that we can see with the traditional shockwave lithotripsy. And it can break artificial stones and human stones, including calcium oxalate monohydrate and as well cysteine. So, in my opinion, the best advantage of the main advantages of the first wave lithotripsy is that it reduces the production of cavitation bubbles. So it reduces the attenuation of the cavitation bubbles because the presence of cavitation, or if we increase the duration of cavitation bubbles around the stone, we are going to reduce the effectiveness of the next waves, and so we are going to reduce the fragmentation. So if we reduce the cavitation bubbles, we reduce the attenuation from subsequent waves, and we increase not only the fragmentation, as well we increase the quality of fragmentation. So we can obtain finer fragments that we can obtain with extracorporeal lithotripsy. And of course, if we use a low peak pressure, we are going to reduce as well the potential tissue damage that we can produce with extracorporeal lithotripsy. So base wave lithotripsy is a safe endoscopy procedure and is well tolerated by the patient, and it can produce we can perform in awake patients, and therefore it's a low radiation procedure. But in my opinion, the most important advantages of this technology, of the base wave lithotripsy, is that you can detect the tissue injury in real time, because endoscopy manifests as an increase of echogenicity. So the threshold duration of echogenicity for more than 20 seconds has demonstrated a correlation 100% with base wave lithotripsy related renal injury. So you can detect the tissue injury in real time, and in these cases, you can stop the treatment and increase the safety of the patient. But the base wave lithotripsy endoscopy have an important disadvantage. It can get an effective fragmentation, but it has a delayed dispersion of the fragments. The solution to that delayed dispersion of the fragments that it has endoscopy produced is the combination of base wave lithotripsy with ultrasound propulsion at high rate, looking for the synergistic effect. Because endoscopy, it has been demonstrated that the combination of base wave lithotripsy with interleaf ultrasound propulsion can increase the comminution rate. And so it has demonstrated that using the same base wave lithotripsy settings, if we increase the rate of ultrasound propulsion, we are going to increase as well the comminution endoscopy rate of these patients. And there are many mechanisms that can explain endoscopy this synergistic effect. Because if we interleave ultrasound propulsion with base wave lithotripsy, we are going to facilitate the release of loose fragments on the surface of the stone. We are going to we are going to get the reorientation of the stone and redistribute the stress and the stress fractures on the stone. The ultrasound propulsion can prevent the accumulation of bubbles and debris that may provide a shielding effect on the stone and decrease the effectiveness of the subsequent endoscopic waves. And finally, the ultrasound propulsion plus base wave lithotripsy can increase the stress factor and help oscillate the collapsing endoscopic bubbles during the treatment. increasing as well the effectiveness. But the main limitation of using ultrasound propulsion is that with the current probe, the target object can be moved only in one direction, in the same beam axis. Recent advances in difference endoscopic proof has got to produce uniform two-dimensional acoustic beam shapes and create high enough pressure confined to a focal region where large object can be trapped and can be moved both along and transfer to the beam axis. So the new technology, the new advances of acoustic trapping is improving the possibility of the possibility of the synergist effect with best wave lithotripsy. The main limitation is that ultrasound propulsion is not yet clinically available, but I think that the combination of both technologies is coming soon. And in my opinion, is the next exit, is the future of the extracorporeal treatment. Another novel application is the histotripsy. Histotripsy is a specific type of HIFU technology that needs a fluid tissue interface. So it's ideal for the treatment of urinary stones. In vitro is used to fractionate tissue structure, to treat fibrotic tumors or to fractionate cardiac tissue in order to create endoscopies. But the main problem with the histotripsy is that it generates Raman bubbles for more than 100 microseconds. And so it can produce a shield effect on the stone and reduce and increase the attenuation or reduce the effectiveness of the next endoscopic waves. So endoscope for its application in the treatment of urinary stones, this technology needs an important progression or needs new advances to be applied for the treatment of urinary stones. And the last application, the novel application, is the microbubble lithotripsy. The microbubble is a solution of microbubbles with a central carbon gas and with a phospholipid distributes in the surface that can be modified to having binding domains. So it has demonstrated in vitro the attachment of these microbubbles to calcium-based stones in vitro. And so in these cases, you need to introduce the microbubbles in a retrograde fashion every 90 seconds, and the microbubbles attach to the calcium-based surface. And then you can apply an ultrasound with a low intensity. It's really it's not necessary to use a high peak pressure. You can use very, very, very low peak pressure between from 0.2 to 1.2 megapascals, but with a high rate, is more than 300 kilohertz. In these cases, the main advantage is that you are going to do a precise treatment on the stone with this technology. And so, this technology is going to increase the erosion efficiency on the surface of the stone, and it requires very, very low energy. So, this technology, when we can apply or clinical, or when we have a clinical apply, perhaps, we are going to have a very safe treatment for our patients. Improve the safety because it doesn't produce tissue damage. So, in conclusion, in my opinion, and according to the scientific literature, the future is moving towards the best wave lithotripsy and microbubble lithotripsy, because both of them improve the safety of our patients, improve the fragmentation and the quality of the fragmentation using focused ultrasound waves. Thank you very much for your attention.
Thank you very much for this nice talk and for this glance into the future. My first short question would be all those future treatment modalities. We have seen for the burst wave lithotripsy the first publication with 2 people, really real life people treated. But when will they be ready to come? Are we talking about next year? Are we talking about 5 years? When it's realistic that we can really treat patients with these methods? What do you think?
Yes, I think that it's not easy because really the burst wave lithotripsy is easy because you are using ultrasound technology, so it's easy to apply only in renal stones. It's not easy to apply it in ureteral stones because it's difficult to localize by ultrasound this type of stone. The burst wave lithotripsy is the main problem that I think is that it gets a very good fragmentation, but the dispersion of the fragment is really a problem for that. So I think that the burst wave lithotripsy needs to be improved moving in the fragment. So I think that the combination with the acoustic manipulation of the fragment is needed to improve the results of the burst wave lithotripsy. I know that there are a lot of years working about that, but in my opinion, I think that if both techniques are well combined, maybe it will be the future of the treatment because it have demonstrated that can fragment all type of stones. And the only difference between the hardness of the stone is the time and the frequency that you have to use. If the stone is harder, then you have to use more frequency and more power. But really, it can break or it can fragment all type of stones. So I think that it needs to be perfect. It needs to be adjusted. But I think that in a brief time, it maybe will be the extracorporeal treatment, is my opinion.
Okay. I've another question, maybe to both of you. When we, as urologists, decide what kind of treatment we want to do, we look for stone-free rates, we look at complication rates. That's what we tell our patients, and many patients decide for uteroscopy because it might be a higher stone-free rate. But on the other hand, Kemal said it, many patients decide for SWL, at least 50% of the stones in his department. And then we look at something completely else. If we look at health-related quality of life, for example, we see that systematic review has demonstrated this several years ago, and studies also comparing SWL with the rears or ureteroscopy demonstrate that SWL is usually favored by most of the patients. And stone-free rate is not the primary judgment for those patients, but they have a higher quality of life after SWL compared to other treatments. What do you think about that? Isn't that decisive for what we should recommend to our patients also?
Yes, I think that the quality of life is important. And also we have some studies in which in our department, we have compared the quality of life of different treatments. And in our experience, the quality of life is very similar between both treatments. The difference is in the cost of the treatments. But when we compare extracorporeal lithotripsy with endurologic treatments, the time of work and for the patient is less for extracorporeal lithotripsy. And patients have a quick covered that with extracorporeal lithotripsy that endoscopic procedure. So in our experience, patients, in order to evaluate the quality of life, prefer extracorporeal lithotripsy than endurologic surgery because the time off is shorter for extracorporeal lithotripsy than endurologic procedure. And the patients look for the quality of life. They want that the pain stops and to come to our lives. So I think that extracorporeal lithotripsy in this aspect is really better for the patient. So in my experience, with different studies, we are comparing different techniques. Extracorporeal lithotripsy is more cost utility than endourologic procedure. Other thing is what urologists think about it, because our main aim is to reach the stone-free rate in a patient. But for patients, the stone-free rate is not really the main objective for them. They want to recover the quality of life and stop the pain and recover their lives. So I think that extracorporeal lithotripsy have an important role in this aspect. I think that, I don't know what is the opinion of Dr. Sarika, if are you agree with me, or do you think another opinion about that?
No, Alberto, Christian, I totally agree with you. Quality of life is becoming more and more important for the patients that we didn't think in the past too much about. Remember, always we thought about the success rates, complication rates, stone-free rates, and these are all for us. But we didn't think about the patient status and quality of life. It is becoming important and gaining importance. We need to think about it also. And regarding management on a stone-sized based manner again, for a 1.2 centimeter stone in renal pelvis, let's think. There are two options. Maybe there's sometimes for some others, those are three options. PNL. I know some friends, they are performing mini PNL for a 1.2 centimeter stone in the renal pelvis. They perform. Let's get rid of it. Don't think about it. RIRS and shockwave lithotripsy. Anesthesia is, on one side, is a problem for the patient. On the other hand, complications I don't think about and tell nothing about them. And after the procedure, JJ stenting is, in the majority of the patients, a real fact. And a second anesthesia to remove it. Stent-related problems. All these things are really need to be kept in mind. When we compare shockwave lithotripsy with other options, but again, on a stone-sized based manner, on a good indication and patient selection, I think that really we need to think about what to do and how to explain the old procedures to the patients. And on the other hand, I emphasized in my presentation, reimbursement system is very important. Again, if the reimbursement system pays the same amount of money for RRS and one shockwave lithotripsy for a stone, 1.2 centimeter in renal pelvis, how many percent? What's about maybe the percentage of the urologists to perform RRS for that stone? I think there will be very, very less. That's why we think about ourselves, our conditions, our studies, and our success rates. But on the other hand, let's make some empathy, go other side, and feel yourself as the patient. Please tell everything in detail to the patient about the complications, need for anesthesia, need for stenting, and the rigid tube in the ureter, access sheet. All these things need to be explained. Then patient will decide, depending on his or her stone, to be treated.
Maybe when we talk about shockwave lithotripsy or the future therapies, I think before the future will be here, we are still able to improve our results of shockwave lithotripsy. I mean, for years we talk about mechanical percussion, which can improve the stone-free rate by 10+%. You demonstrated that coupling can increase the success rate by another 15%. I mean, these are big numbers. Which treatments can you just by adding another effect to it increase the success rate by 10 or 15%? That is huge. And there are several other aspects, giving diuretics, for example, and so on and so on. So I think it is very important, if we perform SWL, not to have it treated like an orphan, to have the youngest guy doing it. I mean, we can also talk about having technicians or dedicated urologists or whatever it needs. But I think this is the first thing actually we have to do, that we give a perfect treatment. And then we can really compare it and look for the quality of life. But I think this is the first step. And maybe I just want to put this back into your memory, just that we have to think about it, and that we really should stick to it. I think. What do you think about it? I think there are many ways to increase the therapy still nowadays.
Yes, yes, exactly, Christian. You are right. Just one comment to that. For example, a specially designed table from China is being more and more commonly used at least in China now, and I'm sure in the future in all parts of the world it will be used. They are performing shockwave lithotripsy, and then they are bringing the patient to this specially designed table. Table is moving, table is changing position, and some percussion to the side of the stone, particularly for lower cold stones. And in the end, the stone particles, just after the shockwave lithotripsy, will have the chance to change its position, come to the pelvic position to pass them easily. The results are promising, very successful, and as you told, some additional, let's say, parameters or therapies in order to facilitate stone passage, diuresis, changing position, percussion, and especially designed table will help us and increase further the stone-free rates.
Yes, I agree with you. Yeah, I agree with you. And in my experience, we changed the technician for the urologist. We increased the stone-free rate with extracorporeal lithotripsy in more than 20%. So I think that it's important to do a proper selection of the patient, a proper selection of the stone, and it's very important that the technique will be performed by urologists. It's necessary. In our experience, we increase a lot the stone-free rate and when we change the technician for the urologist.
And Christian, sorry for one more comment, very important for me. In children, please, shockwave lithotripsy need to be really in the first place. For stone sizing less than, let's say, 2 or 1.5 centimeter, it should be. I don't like the word should, but now I will use it. It should be in the first place to be preferred to treat stones in children. That's the reality, and we should keep in mind.
Absolutely, that's true. That's also the recommendations, actually. Is there, in children, is there a certain age group where you would like to emphasize this the most? I mean, we know when we perform retrograde intrarenal surgery, some say a child should have a weight of 20 kilograms or 25 kilograms, something like that. Is there any range where we would say children from that to that age are first choice SWL? Would you say also a teenager, or is there any limit for you?
No, actually not. I may say that after the age of 1, we have the experience to treat children with stones with shockwave lithotripsy. We can treat, but if it's not urgent, if it's not needed, then we try to postpone the procedure under close observation. Otherwise, in one study, we were able to show that children after the age of 10, they are able to tolerate the shockwave lithotripsy without anesthesia. Pseudoanalgesia is really adequate in this group of pediatric cases after the age of 10, but children with age of less than 10 years, they need anesthesia in the majority of cases. But I remember a case, 1 year old, 2 years old, maybe treated with pelvic stones. Indication was really needed, obstruction was really present, and we performed shockwave lithotripsy. There is no, let's say, contraindication, but we will try to avoid this type of treatment in the growing kidneys of this specific population as further as possible, if possible.
So if they're asymptomatic, if there are no stone-related events, you say you should wait until the child can mature a little bit more, and then you go for treatment. That's what you're saying.
Exactly.
Right?
For example, a 5 millimeter stone in the lower pole in a child, if there is no infection, no pain, and then we can follow the case with appropriate medication in collaboration with pediatric nephrologists, of course. Then, as the time comes, when it gets older enough, we can go further and treat.
As you said that, we also have questions like this from our audience and children. What about SWL treatment of cystine stones? Is there anything you would recommend, or would you make it dependent on maybe the X-ray pictures. Some say it's a little smooth or it's a rough stone. Is there anything you would recommend with your experience on cystic stones in children?
Alberto, do you want to say something? Or?
Yes, I agree with your comments about the child. We have experience as well. And for us, we treat childs with general anesthesia, of course, and we try to use the sonography location for that. We have no limits of age, and sometimes we have a very small child to treat. And the advantage of the child is that they can expel very easy the ureteral fragment. So we try to avoid the ureteroscopic in very small childs. But in our experience, we have very good results with extracorporeal lithotripsy, and we try to treat with extracorporeal lithotripsy, and only use percutaneous surgery for hard stones, 16 or calcium electrolyte monohydride for more than 20 millimeters. But our indications are very similar to adult people, but we have no limits of size of the child to treat with extracorporeal lithotripsy.
Christian, related to your question, we have really limited experience with shock lithotripsy in cystic stones, limited number of patients. But shock lithotripsy is not my first preference to treat cystic stones. If the stones are multiple, if the stones are large in size, it's not in the first place to treat them. We should be very selective. Parenthesis, medical management is very important on this aspect. Highly recurrent stone forming cases, all these cases, multiple procedures. And we know that depending on the stone texture, stone chemical composition, shock waves are not really successful to treat them. If the stone is a single stone, small stone, we can try to treat it if we see them well, because they are not really highly opaque to see them and to monitor them during the treatment. We can try, but in general, cystic stones are not good candidates for shock lithotripsy.
Absolutely. I think the time has passed. We are already at the end. We have many questions left. We have more than, I think, 50 questions that are left. I think there's very interesting maybe to perform another webinar in the future, maybe addressing those questions. Finally, I want to thank you both very much for those talks. I think it was very interesting to have a glimpse in the future, and also to see that SWL definitely is not dead. It will have a kind of new, maybe revival, but before we are at this stage, I think we will have to do our homework and really get SWL to that stage where it belongs at this moment, so we can improve a lot right now. If we look at our data, so we can really improve the SWL, what we already have. I would like just to say that we had more than 300 participants, that we still have more than 280 participants. I want to thank them very much for their audience and for their active participation. And I also want to point out that as we have a lot of webinars those days, the next one from ULIS, the next one on genetics and stone disease, which is, I think, a very interesting subject, and this is something also for the future that will come. This will be in February, so information will be sent out to participants. And I'm really looking forward to see that and to see you back again soon. And again, thank you for everything and for your talks. And I wish you a very good night, good evening. Maybe you want to say something, last word. Kemal?
Thank you so much, Christian, for the EAU and School of Urology for the organization of this nice webinar. I'm sure that the participants did get what they needed, and thanks for the excellent moderation, as always.
Berto?
Thank you very much. Thank you very much for your organization and moderation. I think that it's a pleasure to take part in this webinar, and thank you very much for your invitation.